My name is Dr. Barbara Hostetler, and I am an OBGYN at Upland Hills Health. And I think one of the things that sometimes people don't realize about the services that are available in a small hospital, especially if you have board-certified obstetrician gynecologists there on staff, is that we can really provide almost the entire full spectrum of care obstetrically and gynecologically for most women. And I would hope, and what I want from my patients, is that when they come into the office to see me, they feel like here's a place where I can focus on what I need. I can ask whatever I want to ask. I have lived by the mantra that there are no stupid questions. And I hope you'll always feel free to ask me anything. Anything. And I mean that. Things that are inconvenient, but maybe, clearly not life-threatening. They are bothersome. They can be uncomfortable and sometimes even painful. They can be embarrassing. But women tend to forget when they're distracted with the care of the rest of the family. Or they think they're the only person who has this problem. And I would say those problems include things like incontinence, which can lead to some very distressing behaviors, like limiting the times you go out of the house, like changing the way you manage your social life because you're worried about having an accident. Symptoms like pelvic pressure, which are not terrifically uncommon. They probably affect at least 30% of women on some level, and yet women are less inclined to come in and say, I have this problem. What does that, what do you think of this? And in many of those cases, I would say the high majority of them, maybe as much as 80 to 85%, we can offer some kind of treatment that will improve those symptoms. Maybe it's surgery, maybe it's medical therapy, maybe there are other non-surgical options for management, but they're symptoms that affect the quality of life in significant ways and can down the road change behavior in a way that is not healthy. And yet people are reluctant to come in and make time for themselves to get evaluation and treatment for. So one of the things that I like to use when I'm talking to my patients about symptoms like incontinence and pelvic pressure and pelvic pain, another symptom would be that they feel like, quote unquote, something's about to fall out. Okay? Those are very common ways that women describe the symptoms associated with prolapse. So what is prolapse? Prolapse is when the structures of the pelvis that are keeping organs in place begin to relax, whether that's because of injury from childbirth, genetics and the kind of connective tissue that you inherit, which is probably one of the biggest contributors to pelvic prolapse. The fact that we stand all the time. We lift heavy things. There are lots of things that can contribute. But one of the things that I like to do is show people their anatomy, because most people don't really know, unless they've taken an anatomy class or they've looked it up or they've been motivated to find these things out, what exactly is happening when prolapse occurs. So I like to use models in my office, and most people find them pretty enlightening and helpful in terms of understanding not just what's happening to them, but also being able to explain, here are some treatments that I can offer you that, and this is why they work, or this is why this particular option might be good for you, okay? So I like to start with this model because this is actually a life-size model, and show people just even three-dimensionally how the uterus sits in the pelvis. And then I like to take this out, because then what I can show people is I can show the anatomic relationship between the bladder, the urethra, the rectum, and all the tissue planes that are involved in the course of prolapse. And to me, this is a really, I think part of my role as a physician is to educate my patients. And when I educate them, they're much more likely to have a better healing process. They're more likely to be maybe compliant with the restrictions of, say, surgical procedures. And I think they just feel better about what they're doing because they know why we're doing what we're doing and how it's supposed to work. You know, from a surgical point of view or from an anatomic point of view, if you look here, the tissue planes between the rectum, between the bladder and the bladder neck and the urethra, they're pretty thin. And this is pretty, you know, this is a model, but when you're operating, this is pretty much what you run into. These tissue planes are very thin, and yet they form part of the support structures that keep the uterus in place, okay? There are ligaments here called the uterosacral ligaments, and these also are very important structures in terms of keeping the anatomy in place. And when these structures get damaged, say from childbirth, from a laceration, and just because maybe you inherit connective tissue that's not as strong as your neighbor's, they degrade like everything else over time. They may not recover from injury as well as somebody else's. And so what happens is, here's the uterus, and as those support structures weaken over time, the uterus can fall down through the vaginal canal, and even in the worst case, something called complete prolapse, the uterus can actually come out, okay? And, you know, a herniation is kind of what I use as an example. When you have a weakness in the muscles of the abdominal wall, so the abdominal wall isn't keeping the contents inside, the bowel can herniate through. And to some extent, this is also a herniation of the pelvic organs. You can't appreciate it as much from the model, but there are muscles that create the floor of the pelvis. And when there's an automatic weakness here just because the uterus is here. That's what allows us to have children. But the support structures that feed into that, as they weaken over time, which they're going to just with the aging process, then you're going to have herniation of abdominal contents through that weakness. So this is not your fault. You know, women like to blame themselves for things sometimes. And you didn't cause this. If you're having children, you're having children. You don't have control over the labor process and how it comes out necessarily. You don't have control over the connective tissue that you inherit. And whatever your job is, if it involves heavy lifting, that's your job. And so, you know, we all do the best we can. And for some of us, this becomes a bigger issue, a more symptomatic issue than it does for other women. People put up with things for a long time. It's amazing when it comes to prolapse and incontinence, how long women will put up with this. But that said, there are lots of options for treatment depending on the level of prolapse, the kinds of symptoms you have, and one of the common things that will come into my office is that somebody will come in referred and say, my doctor said I have prolapse and I need surgery. And the good news about that is that that's not always the case. And unless you're symptomatic, prolapse is probably, to some degree, is highly prevalent in women once they reach the age of 60, 65 or more, okay? We probably, all of us have some level of it, but the bottom line is prolapse is not life-threatening. It can be extremely painful in extreme cases of it, but it's not a life-threatening situation like a massive heart attack or a ruptured appendix or something along those lines where you need to take care of it right now. I think the luxury, if there's a luxury of prolapse, is that you have time to consider what your options are. You can make decisions about how you want to be treated. And in the context of very mild prolapse and the absence of symptoms, that's the question I ask my patients is, are you having symptoms? And if they're not having any symptoms, they're not having any pelvic pressure, they're having normal bowel function, they're having no problems with incontinence, they're not having any pressure, then I will tell them, you don't need any treatment right now. And if that changes, then I want to see you back, okay? Here are some things you might be able to do to help strengthen the pelvic floor. Will they prevent future prolapse? Probably not. If it's going to happen, it's probably going to happen. But it's something you can do to maybe try to make the pelvic floor stronger in the meantime. So how you get treated, the options that are going to be offered you are going to be a function of what are your symptoms, how bad are they, and other things like maybe other complicating medical conditions. Maybe you have more pressing issues at the time that you might be a candidate for surgery from a prolapse and an anatomy point of view, but maybe medically it's not such a good course for you now or at any point, depending on how complicated your medical history may be. So there are non-surgical ways of dealing with prolapse, and those should all be explored for any patient regardless, so that you can make a decision that you think is best for you. The other benefit of non-surgical methods is that if they help you, you can use them to some degree indefinitely until you reach a point where you want to have surgery, it's convenient for you to have surgery, you can have a support system in place to help you with the proper recovery, because that's going to be important to your long-term success rate. And then you can decide, what's best for you. So the spectrum of symptoms that can go with elements of prolapse can be all over the board. And so therapy really has to be individualized to the things that are bothering the patient the most and the context in which all of that is happening. So for instance, incontinence. There are different kinds of incontinence. Some of it is anatomic and may be related to prolapse, and some of it is not related to prolapse and anatomic changes. And how you treat those is going to be different. So if it's stress incontinence is an anatomic issue. The bladder neck and the control mechanisms for what allows us to not lose urine when we cough, sneeze, jump up and down, pick up something heavy, go up and down stairs. When we increase the pressure in the abdominal cavity, there's a neurologic, physical, anatomic, muscular mechanism in your body that pinches off the urethra so that you don't lose urine. But if those relationships anatomically get thrown off by the prolapse or the dropping down of the areas of the bladder neck into abnormal positions, then those mechanisms won't work. And so you cough, sneeze, you lose urine. And maybe it only occurs when your bladder's really full because you didn't go to the bathroom all day long, okay? But if it's occurring almost every time you cough, sneeze, then you very likely have an anatomic problem that might respond to, say, a physical correction. And you can do that physical correction with surgery, but you can also do it with devices that are called pessaries, and I'm going to talk about that a little bit more. There are other forms of bladder, incontinence, more like urge incontinence, overflow incontinence, when you get out of bed and you can't get to the bathroom in time. When you say, I've got to go to the bathroom, and suddenly it's dribbling out before you even have a chance to get to the bathroom. Those may be responsive to medication. You could have a urinary tract infection. Uterine prolapse can be associated with stress incontinence. It can also be associated when the bladder wall, when all of this falls down and the wall of the vagina under the bladder gets pulled with it. That's called a cystocele. There may be incomplete emptying of the bladder, which can lead to other problems. And so surgical correction, physical correction may help some of those issues. And that's where you start getting into a discussion with your physician about how do you make this better. There are surgical ways of managing this. But there are also non-surgical ways, and I think that's one of the things that surprises patients when they come in. They're not always aware that there may be a non-surgical way of addressing their symptoms. And pessaries, which are really kind of old-fashioned devices in a lot of ways, they've been around for a long time and are making a big comeback, are devices that you can put in the vaginal canal to push the anatomy back and try to hold it in place to recreate normal support structures. And they can be used in a variety of ways. They can be used as a way of treatment. They can be used as a temporizing measure until you have time to have surgery, because surgery often requires a good 6 weeks of recovery at least, where there are going to be restrictions imposed on you that you need to pay attention to in order to have a successful recovery. They can, and I like to use them sometimes as a diagnostic tool as well, because if I put one in and your symptoms improve, then I can feel some reassurance that surgery is going to improve your outcome, that you're going to feel better after surgery. But then at the end, it's your decision to decide, do I want surgery? Is it right for me? When do I want surgery? When is it convenient for me to go through this process? And a pessary can do a very nice job of managing those symptoms until you get to the point where surgery is maybe the thing that you want to pursue. This is not an insignificant issue. And incontinence is not normal. There are many, many, many causes of incontinence. Some of them are serious and can change the course of your health care. It's not normal to have pelvic pressure or to feel like something's falling out. And I think I can reassure you that it's not going to fall out, but it's not normal. And it's something that you should feel like your daily activities of living, your quality of life matters. And this is something that every gynecologist out there is very happy and trained to talk to you about. So please don't hesitate. If you're worried, we're worried. And if you feel like something's not right, we want to see you.